Okay. So what I'm going to talk about for the next 20 minutes is spinal fusion surgery and which is the best way to go. So there are different ways to approach spinal fusions. I should have apologized. I'm talking about lumbar fusions here, so lower back, and the different options you have and which option you should choose for which cases as best as we can. So, of course, spinal problems, they go back for centuries. We've been operating on the spine for a very long time, for centuries. But, of course, the technology has slowly advanced from no instrumentation to some instrumentation. The education process has very much changed. So in the olden days, this is how we were taught spinal surgery. But, of course, that's now changed to things like this, conferences like this, and, of course, in the operating room as well. And we just saw the last speaker showed a very nice picture of a modern operating room with an intraoperative CT. So initially, spinal fusions, because that's what we're talking about, lumbar fusions, were in the basic form of something like this: simple posterior pedicle screw fixation, no interbody work, posterior lateral grafting. So this is putting some bone substitute or bone at the sides to allow fusion to take place at the back posteriorly. So not much in terms of interbody. That was the classic way to do it, and we've advanced since then. So so let's talk about fusions. What are the actual reasons to do a fusion? What are the indications to do a fusion? Well, the main indication, of course, is an instability. So if the patient has an instability, and I spoke to you before about flexion extension views to look for an instability. But there are many reasons for instability. So a degenerative reason, a traumatic reason, and Dr. Ewan showed us some of her trauma cases, an infective or inflammatory reason, or tumor, cancer, oncological reason, which I showed you a little bit before. So that's one reason to operate. But also just sometimes pain. And there's a breakup of this. So pain in the back, but also pain in the leg. Pain in the back is controversial. So it's accepted now around the world that fusion surgery for back pain alone may not be the best idea. Okay. But what we do it for is leg pain. So if you've got a foraminal stenosis, so the little holes where the nerves come through the side of the spine, if that hole is compressed, if that foramen is compressing the nerve, sometimes the only way to open that up is by bringing the two vertebral bodies apart with an interbody fusion. So what are the options for fusion? There are so many ways to fuse somebody. You can go directly. This is obviously a specimen looking from the side. So it's an axial image, but placed on the side. So this is the abdomen. This is the patient's back. So posterior lumbar interbody fusion, transforaminal lumbar interbody fusion, extreme lateral interbody fusion, or an anterior lateral interbody fusion. And there's also an OLIF approach, which is somewhere in between an ALIF and an XLIF. So which one do we use? Now, in my opinion, if you're going to be doing complex spinal surgery, you should really be able to do most of those, if not all of them. And you should have it as an option for you to decide which you want to use. It's kind of like a rich person having a sports car, a 4x4, an electric car, and a very small car for when they're going around town. They choose which car they want to use according to the day. They have all the options available to them. It's the same for a spinal surgeon. You should have all the options available to you, and you choose based on the day, on the case, which one you're going to use. So what are the deciding factors? Lots of factors should go into your mind when you're considering which approach to make. Patient's age, their sex, so male versus female. Why is that important? For example, in an ALIF approach, one of the complications is retrograde ejaculation. That means that patient can no longer have children the normal way. So lots of these things come into play. History, so if they've had previous surgery, if they've had lots of extensive abdominal surgery, you might not want to go from the front. Or if they're like very big, if they're like me, you might not want to go from the front. Yeah. I mean, I'm probably the cutoff limit, but if somebody had a very big abdomen, you won't want to go from the front. It's not feasible. Religious beliefs. If the patient does it, so some religions, they're not allowed to accept blood transfusion. you probably don't want to go from the front, because if you get a vascular injury, you can't give them blood. So somebody with a religious belief, you might want to go from the back where the risk of blood loss is lower. So all these things should be going through your mind when you're making a decision. The pathology, is the problem degenerative? Is it traumatic? Is it infective? These factors make a decision as to whether you're going to go from the front or the back. Is the pathology hard? Is it disc pathology? Is it a bone pathology? What's the pathology? Is it coming from the front? Is it pushing in from the back? Is it foraminal? What level are we talking about? I mean, we're generally talking about lumbar, but upper lumbar, lower lumbar, all these things make a difference to your decision. Your comfort, of course. So if you're somebody who just does posterior all the time and you do it really well, you know, maybe that's what you need to be thinking about. Consider the other options, but if you're comfortable doing that in your hands, you're better off doing what's safe for the patient. Of course, hardware availability, that's very important in this part of the world. If there's no ALIF cages, well, you're going to go from the back. The other thing you should consider is sagittal balance, and I'm going to go through this very, very quickly. I'm not going to waste my time with this, but basically, sagittal balance is basically the spinopelvic alignment in the sagittal plane. And as one of the American surgeons put it, keeping your head over your ass. That's how he put it, you see. So what it means is this. It's this balance. So this is poor sagittal balance, and that's poor sagittal balance. This is good sagittal balance. This is coronal balance. Okay, so that's what we're talking about. I'm sorry to state the obvious, but sometimes it's better to do that. So this is what we're talking about. So it's a plumb line. So the plumb line from your cervical spine going through the L5S1 disc space, that's a normal plumb line. You see, it says here the plumb line should pass through the L5S1 interspace from C7. Up until 5 centimeters is relatively normal. Anything more than that is abnormal. So something like this, these patients here, these have no abnormal sagittal balances. And so we can correct that by bringing them back. Why is that important? Because we know through multiple studies now that a disruption of the sagittal balance does lead to problems. And if you don't correct the sagittal balance, then the problem you've just fixed will get worse down the line. I know that Professor Drummond doesn't believe in sagittal balance, but that's fine. Do you believe in the tooth fairy? No. All right. And also, so some studies have shown that quality of life outcome in people who have been sagittarily aligned is better. So there's definitely some evidence that it's true. And this is what we're talking about. It's lots of funny calculations, and you've got to get to within this realm. And just very lastly, this is what we're talking about. So a patient with poor sagittal balance, this is what they're like. So it does affect their mobility, their quality of life. And when you realign them properly, they're able to stand, and it corrects lots of factors, quality of life, mobility, etc. Now, let's get back to spinal fusion surgery. So what are the advantages and disadvantages of all those approaches that I spoke to you about before? Let's talk about them one by one. So this is now from the front. This is the ALIF. So what's the advantage? Large footprint. So, you know, you can put in a cage from the front. The larger the cage, the more likely the patient's going to fuse. You can put bigger graft material, and the less likely that one body is going to collapse onto the other, or subsidence, as we call it. You can also restore the sagittal balance. If I remember the picture before with a lady like this, if you get in from the front and open up the anterior longitudinal ligament and you put in a big cage, you can correct them more. Okay, you can't do that so well from the back. All right, good fusion rates, the recovery is pretty good, and you can do this alone, so you don't need to go from the back. Why is that important? Sometimes if you leave the muscles at the back and the ligaments intact, their recovery is better, and the physiotherapists, they love that. Disadvantages, we spoke about the risk of injury in males of retrograde ejaculation. Vascular injury is much higher. You sometimes require an access surgeon. There are lots of factors with this. I'm going to try and plumb through this quickly. Posterior, this is like the most used technique around the world by far. It's the gold standard. And it's got advantages. So it's well known. So that's the advantage. Most of us are taught this. The risk of vascular injury or bowel injury is almost none. You can deal with direct pathology. So when you've got big facet joints and things squashing the canal, or the nerve roots are squashed in the foramen, you can deal with that directly, and you can see the nerves decompress directly. So lots of good reasons. I won't go through all of them. Disadvantages: small footprint, and where is it on here? Can't be standalone, so you need to put posterior screws in. And obviously, the sagittal balance realignment is nowhere near as good. Lateral, similar to the ALIF, so very similar factors to the ALIF. You can avoid the injury to the autonomic system, so they don't get the retrograde ejaculation. But it does have a risk of injury to the bowel. There is a slightly, and to the lumbar plexus, and actually that risk is higher in skinny patients. So in fat patients, the fat plane, the fat tissue creates a plane for you, so it moves everything away. In very skinny, be wary of very skinny ladies for this. Skinny females, you're much more likely to cause a vascular injury. And then OLIF, very similar to ALIF, and something in between ALIF and an XLIF. The difference is you don't go through the psoas muscle, so the risk of injury to the nerves is much lower. And this is just an overview of everything we've spoken about. So what we've done is we've broken this down into which one's good for sagittal balance. You can see ALIF is the best, probably followed by lateral or OLIF. Graft window is similar for all three. But for example, a PLIF is really good for L1 to L4 levels, and you can do, in fact, all levels, sorry, for this case, whereas for ALIF, you can't do an L5S1. Sorry, you can't, sorry, for an XLIF rather, you can't do an L5S1. Okay, so there's lots of factors there. So in the last 7 or 8 minutes, we're going to just try out some of these options. So this is the first case. So this is a 48-year-old male. He's already a father of 3. He's had 2 previous discectomies, and the disc prolapse has come back, and he's got worsening back pain and recurrent leg pain. So what are the options for this patient? Well, there's always the option of conservative. Remember we spoke about this before, for anything in surgery, you never have to operate. There's always the option of managing them conservatively with a pain specialist, injections, physiotherapy, etc. There's, of course, the option of doing another microdiscectomy, but this is now going to be their 4th. Probably not a good option. Once they've had more than 2 or 3 recurrences, the chances are it will keep recurring. You really need to look at another option. And so the other option, of course, is the fusion. So let's look at the options for this particular patient. So he's a 48-year-old dad. What will a PLIF do? Well, it will deal with the direct disc pathology, so you can remove the disc. You can get a direct decompression of the nerve roots. The bad options are there's going to be scarring because he's had 3 surgeries before. The higher risk of injuring the nerve. The cages that you put in has a smaller footprint, so subsidence risk is higher, and you can't use as much graft inside the cage anyway. You do need to put screws in, and it won't help as much with the sagittal realignment. So there's good and bad of doing a PLIF. Now, if we look at an ALIF for the same patient, it's a fresh approach, so you don't have to worry about scarring. You can get a very good indirect decompression. You can achieve a really good sagittal realignment. You can do it standalone, so you don't need to go back to the back again and cause more muscle harm by putting screws in. Of course, there's a risk of retrograde ejaculation, but if the patient is happy that he's already completed his family, then it's not so much of an option. But you do need to consider cell saver and getting a surgeon to do that for you. And this is the kind of thing you can achieve. So putting a cage in from the front, you can see you can get very good realignment there by putting in a hyper or a lordotic cage. And you can do this standalone without any instrumentation from the back. Case 2, so this is a 51-year-old female. So this is very similar to the picture we saw before, who's already had an L4-5 fusion, 1-year history of worsening back pain, thigh pain, and essentially this patient has adjacent segment disease. So in patients who have a fusion, what happens over time is that the level below or the level above can go. Okay, and we know that the reason for that is that this becomes a hardened level, and so these levels take on the extra mobility with flexion and extension, so they wear out a lot quicker. So what are the options for this patient? Well, again, just conservative. We could just do a decompression to try and fix some of her leg pain, but it might not help her back pain. we can just do a pliff, so we can go back to the back and extend that construct, do some more screws at L3 and extend the rods, or we can go to the side and completely avoid the back. And these are the good and bad options of doing both. So going from the back is direct decompression, but going from the side, you avoid scarring. It's a quick operation, and it can be standalone. And I'll show you what I mean by that. So, so this is the CT scan. You can see on this picture, there's the old screws. So this is the standard pedicle screws that this patient has in L4. And what we've done is put in a cage from the side at L3-4 with some screws in a plate. And that's it. No screws from the back, no need to go back to the back. The foraminal height is restored, the leg pain's gone, and the back pain actually improves with this, just by stabilizing that motion segment. And that's what it looks like on the sagittal plane. So there's the lateral cage, and there's the screws, the lateral screws that come in across like this at both levels. So, in good time, in summary, there's no real right or wrong answer. Okay, there's no right or wrong answer. You can fuse patients in whichever way you want, but usually you'll find there's a better option for that patient, depending on what they've had done before, history, body habitus, male or female, age of the patient, the quality of the bone, you know, should you be fusing at all? All these things you should take into account before you consider surgery for a patient. There are many ways to skin a cat. However, firstly, don't do any harm. If you think you can't do a job properly, don't do it at all, or do the minimum. Do a decompression and give them some space, get rid of the pressure off the nerve, but don't do any harm. Secondly, if you do need to do a surgery, do the method that's going to cause the least amount of damage or harm to the patient, and the method that's going to give them the best long-term outcome as well. And also remember, the one thing that we don't do very well as surgeons is refer. So there's no pride in surgery. There's no pride in surgery. So if you don't do an operation that you think that patient needs, refer to somebody who does do it, or learn the operation. Get somebody to come and do the operation with you a few times until you learn the operation. But there's no harm in saying, I don't do this operation very well. I think this is the operation that will best be for you. I'm going to send you to Miss So-and-so or Mr. So-and-so to do this operation for you. Thanks very much.